healthcare improvement specialist and also serving as the secretary for the Society of Quality Healthcare Education Committee. So it's a privilege and pleasure to have you all here. And without further ado, I'm going to invite Eunice Tole to start taking us through the presentation. Thank you, Eunice. Please go ahead.
Thank you, Esther. I hope everyone can hear me. Let me share my screen. So Esther, we didn't hear what you said about me, but I am almost certain it was spot on. And
no, sorry, I actually said that you will introduce yourself at the beginning of the session. So please give us a brief about yourself before you proceed.
Okay, my name is Eunice. I'm not sure what to say, but I will say that I enjoy quality. I love it. That's who I am really. And most of all, very, very, very humbled. And my favorite spot and place to be at is home with my little children. I will be taking you through this subject, measurement in continuous quality improvement. And bear with me as I do this presentation. I will not put on my camera so that the voice doesn't, or the challenge that we just saw Esther go through. So you will see me perhaps at the end of the presentation. But the objective for me today is to share the different quality performance outcome measure programs or models, present different improvement measure selections designed to produce effective information and indicators of quality, and display methods that can be used to collect these measures and at least show some evidence of monitoring and evaluating improvement results. As I start that topic on measurement, I just want us to go back a little bit and see the journey of the history of healthcare quality. Why are we then measuring? But just a quick brief on the healthcare quality journey and the history, perhaps a little bit more US oriented, but something that we have all adopted. Started in 1863, believe it or not, with Florence Nightingale. And I know you know this particular lady known as the lady with the lamp. She started nursing school in London. She was the beginning of that measure of quality in that way. There were infections during the wars and handling all that in the way she could and starting a nursing school. That was the journey of quality. A few years later, Ernest Codman, and I'm sure you all know Ernest, he was a Boston-based surgeon. He studied outcomes of surgeries. He's actually, and I'll probably put on my pointer, the one who started the American College of Surgeons. And moving on, Avedis, and I know you know Donna Biden, most of you familiar with the elements of structure, process, outcome. Structure has the hospital characteristics. He talked about patient characteristics too, clinical conditions, accreditations, and licenses early in the 1950s. On outcomes, he also talked about mortalities, morbidities, and disabilities. Further on, JCIA-HO started off as a quality aspect, improving standards. It's a joint commission, accreditation of health organizations. That's when it first started separating standards of patient safety as well as organizational standards. By the 1960s, Edward Deming, we know him as, the father or guru of quality, where the Deming's 14 points were started, the 7 deadly diseases, the PDSA cycle that we know so well. Moving on, Durand came through in the 1970s. We are familiar with that, triology of quality planning, quality control, quality assurance. Donald Berwick was right there, again in the quality journey. This one for the pediatricians on board. He was a professor of pediatrics, and he was actually one of the ex-CEOs of the Institute of Healthcare Improvement, where we take a lot of our indicators from. HIPAA came through and acts started coming through, which we also saw adopting in Kenya and Africa as a whole, health insurance, but HIPAA is Health Insurance Portability and Accountability Act, which really started off in protecting health information, looking at patient rights on health. And by 1999, IOM, which is the Institute of Medicine, began the campaign on "To Err is Human," but started looking at the 6 aims. The one we know so well is TIP, something about safety, timeliness, efficiency, effectiveness, and patient-centered. And sooner we were on the Lean Six Sigma, getting to 2010, where ASA, Affordable Care Act, started coming through. And now in the 2013, which is considered the 4th century of quality, IHI, Institute of Healthcare Improvement, with the aim, the triple aim aspect, which is related to population health, experience of care, and per capita cost. So you can just see the whole healthcare quality journey gives you why we are where we are today and why we measure in this 4th era of the quality journey. So in quality measurements, as I've said, why do we want to measure? We want to measure for good reasons. And sometimes I tell myself, if it doesn't make sense, if it doesn't add value, then why start it? So truly, quality measurements, we do it so that it helps us make decisions in healthcare. It not only helps us make decisions, it helps us analyze the data and information for effective performance. And of course, in the ending, we use these outcomes to identify how we measure up, either with our competitors, other practitioners, acceptable quality based on the eye of the patient or the eye of the consumer or the eye of the government, your shareholders, etc. And therefore, then we respond to market changes with exceptional performance and justifying a value-based service. So as we move on to performance improvement models, as I give you examples, I just want to pause here and say, I like Steve Covey's, there's a quote he says, "We are often so busy cutting through the undergrowth that we don't even realize we are in the wrong jungle." Basically, to make an extraordinary thing happen in your organization, wherever you are, you need to have a certain performance improvement model that is driven by certain goals and leadership. And for that, it's the only way you'll be successful. So I start off this again by that first objective. We need to have some models of performance for you to be able to get there. And you need to ask yourself, which model best suits you in your current culture, in your current strategy, in your working area? Which staff are you targeting? How do you want it communicated? Is it current with the current times that you're in? And these are the examples of the models, the Beldridge Performance Excellence Model. Again, this is a program that you can adopt as you implement your quality measures. And in this one, the emphasis here is on, again, measurement analysis, but with an organizational profile where it looks at the environment, relationships, and challenges, basically to get a business result, looking at workforce interchanging with the process management, strategic planning, and the customer as a whole. Another model is the European Foundation for Quality Management. This one is simple: enablers, results. Once you have key results, there is a learning, creativity, and innovation. In it, there is a measure of key results. And here, as you will note, one of the enablers are people, and the results are people results, with a process in between: strategy, process in between, customer results, partnerships, process, society results. Another model, which is known as the balance scorecard. Ideally, a lot of private sector programs, when they're measuring outcomes and even in quality, they tend to use this one, the balance scorecard. Unlike other performance models, the balance scorecard tends to help organizations better link long-term strategy and short-term strategy. Why? The vision and strategy is at the center, making the four financial, customer, learning, and growth and internal business processes. But you will notice in each one of them, there's an objective, there's a measure, back to measure, there's a target, and there is initiatives. In it, that's why you can be able to link. You can have your short-term objectives and your long-term. You will have indicators to see whether you're growing or not growing on all the elements. It's a good model to use, tends to be used, as I said, in private sector more. In, again, effective performance outcome measurement systems, you need to ensure that there's another one that's known as ISO 9001:2015. I repeat, you need to ensure you understand which one you want to take. QMS framework, known to all of us, inputs, outputs, the center of PDSA, P, D, C, or S, A, we all know this one. Another model, Joint Commission International Accreditation, with governance and leadership at the center, dividing standards that are organizational based, as earlier alluded to. Organizational ones are sort of the staff qualification ones, the research ones, the medical education ones, the management of information, that's where your EHR and your electronic health records, etc., comes through, and the facilities. Those and the quality improvement, those become organizational standards, dividing them into that, versus patient safety standards that are specific to the line of implementing patient care. So I pause here again and ask ourselves, even as I've said, it's good to look at which performance model to take, but you have to ask yourself, then which measure is a better measure? And in looking at different improvement measure selections, you've got to choose one that's effective, that gives you the indicators and quality that you're looking for. Because once you've chosen a performance model, you want to ask yourself, what am I then going to accomplish? How will I know that a change is an improvement? And what change can I make? Where I am as an individual, where you are as leaders, where you are as policymakers, what change can we make that will result in improvement in quality? And for that, you can use this rapid cycle. Again, plan, do, study, act. And it can be very small scale to large scale, but you will notice the most important thing is that changes are resulting to improvement and growth. And so you can do it at micro level and replicate it in a wider scale. So in that sense, then you then have to think of where to source these measures. And sourcing measures is available to you and I from all these sources. They measure from specific indicators to professionals, like this one is a database for nursing quality indicators, so nurse-sensitive ones. Some are for surgical procedures, some are overall. So you have a performance model, you are thinking of what will add value, you look for the sources, but after looking for the sources, which are there named, then you look at how will I prioritize them, which measure. And to help you identify these measures, you need to look at your 80-20 rule, which we tend to use in different aspects of our lives. But you're asking yourself, for me to prioritize, am I going to look at establishing a criteria of volume, risk, a problem? Am I going to look at assess the gaps in internal performance? Is that what is going to drive my prioritization? Although I have a beautiful model, as I've mentioned, the different types. Am I going to look at external drivers? And all of them can be used. It's not that one is against the other. External drivers are examples of new regulations and standards. Am I going to be looking at providing information to leaders so that they help me with resources or drive my agenda? Am I going to be looking at a matrix for priorities for decision making using a certain tool? Am I going to be involving stakeholders? Am I going to be looking at internal and external requirements? And obviously, while you're putting that in mind, you've got to report these priorities and indicators in your mind that are comparable in terms of appropriateness. And I mean, if appropriate, also for risk adjustment, for example, factors of age, gender, health status, etc. Availability data that's available to all of, even as you look at the priorities, timely. There's no need of doing all this and prioritizing and not giving results in time, that adds relevance also, that's valid, that can be tested. You can also look at prioritizing with measures that you're good at, you have experience for, that are stable, likely to be removed, that are not likely to be removed, and of course, distinguishability as a measure, even as you're looking at prioritization. And one more that I always add is credibility. That measure needs to be able, even as much as you're prioritizing, to be audited. So once you have thought through performance models, priority, looked at the database, quality measures or indicators are looked at as that element to trigger that improvement. As I said, we know the history now of structure, process, outcome. Measures or indicators are then grouped there. And structure ones can mean infrastructure, capacity systems, processes, tell whether the parts or steps in the system are performing as planned. This can be at the end of the process or at the beginning, for example, timely administration of prophylactic surgical antibiotics, and outcome measures that you and I know so well show results of overall processes. And often, don't forget the element of risk adjustment. Measures or indicators are also known as sometimes as key performance indicators. People use that terminology, KPIs. While you're putting them under structure, process, or outcome, they can be operational, financial, clinical, managerial, etc. And I'll give you an example of that, the structure, process, and outcome measure. Quickly on this one, everybody, if you can see, will think that's so clinical. If you're not a clinical person in the audience, you're thinking, what's acute myocardial infarction got to do with me? And in this one, it immediately throws clinical. But when you look at it, there are structural ones within these indicators, process ones, and outcome ones. For example, the outcome one is 30-day. But a process one is aspirin at arrival, which is adult to balloon time, the use of ARBs and ACEIs. A structure one is the cath lab functional? Do you have the appropriate staffing numbers and skill mix? An efficiency one is the cost of the cath lab procedure, the staffing supplies. A patient outcome one, a patient experience one, was their feedback of assurance, empathy, responsiveness. While yet you just thought that this particular measure or indicator was an outcome myocardial infarction. So you can then divide your measures and indicators into that just based on a clinical one. While you do that, don't forget the criteria of accountability measures. And this includes a lot of measures that accurately capture the provision of evidence. And I'll be moving on to discuss the evidence that's important, and then risk adjustments. I always leave this one because I want people to think through the risk adjustment as a valuable part as you're looking at indicators and performance, because severity adjustment is an important tool to put in mind. Again, I pause here and say, now that you have the performance measures, you know, again, what to look out for, prioritization, where to get it. Then you ask yourself here at this moment, how do I display that? How do I collect this measure? How will I show in the end the evidence of monitoring? And as I say this, I say whichever one you choose, remember, every system is perfectly designed to get the result it gets. So if you design it to produce good results, you will get them. If you don't design it well, you'll get the results that you will have designed your system for. So with that, here are some of the collection measures that show evidence that will help you monitor, evaluate, and improve results. So in this one, it's known as evidence-based practice. Evidence-based practice, as we all know, is that concerns explicit and judicious use of current best evidence in making decisions about the care of individual patients. There are many benefits to using evidence-based practice. because it promotes quality, it's iterative with outcome measures, it complements the principles of continuous quality, safety, and performance improvement. Evidence-based practice and quality improvements are based both on research, clinical research, and health service research. As I've shown you where you can pick some of these measures, Agency for Healthcare Research and Quality is one of the places where we pick a lot of evidence-based practice guidelines. Clinical guidelines and pathways under evidence are also another one where we know what clinical guidelines are. They are consensus statements that are developed to assist in clinical management decisions, while pathways are tools to manage quality outcomes and cost of care. Pathways are documented-based tools that provide a link between the evidence and the clinical practice, and they're a pathway because they map. And here are generally the differences so that I quickly just don't bore you with it, but it's another measure that's very, very good. Pathways, guidelines, and in this one, the practice guidelines, the differences are the clinical practice guideline offers explicit recommendations for clinical decisions making, while the pathway implements the actual practice guideline. And the scope, practice guidelines usually cover specific clinical circumstances, while the pathway charts the care given for the entirety of the clinical course. The developers of pathways tend to be government, associations, non-governmental agencies, while pathways are usually a group of local doctors and nurses coming together or healthcare workers. Between practice guidelines, they are non-institutional. Pathways tend to be institutional-based. Timeliness, no timeliness is provided in pathways, in practice guidelines. But in the pathways, it's designed around a specific time frame. And practice guidelines do not trace a patient outcome, but in a pathway, it is expected that the patient outcome is evaluated for progress. So really, whichever you adopt, just know the standardization of it. Pathways have certain sets, prevalence, etc., and there are details to that. Another model is known as bundles. A bundle is a defined, it's a beautiful tool. IHI, as I've said, Institute of Healthcare Improvement, started it off in 2001. It's a small set of evidence-based interventions for a defined patient and a population. When implemented together, results significantly in better outcomes than when implemented individually. So these little aspects are put together, the interventions. Bundles are designed that include 3 to 5 interventions for that matter. Each bundle element is relatively independent. The bundle is used with a defined patient population, as I've said. It's multidisciplinary. And for this one, you need to note compliance is all or none. And that's the principle that's followed with bundles. An example of where you can use bundles is when you're looking at CLABSI or central line associated bloodstream infections or catheter associated urinary tract infections or ventilator associated events, etc. Another principle is epidemiology principles. This is the branch of medicine which deals with incidences, distribution, and possible control. Another method is population health. This one considers determinants of health, including medical care, social and physical environments related to service, genetics, and individual behavior. And overall, I can just quickly explain this one in a triple aim, as I had suggested earlier, where we are at in the 4th century of quality, which is improving individual experience of care, improving health of populations, and reducing the per capita cost of care for populations. This is another model you can use, which includes all those things: claims, clinical integrity, care management, coordination, patient engagement, etc. Another model is audits. This is just to give you the history. Audits have its place, started many years ago, valid, it's criteria-based, and that's why we use audits, which essentially is defined as a process that has been, that seeks to improve patient care outcomes through a systematic review of care against an explicit criteria and the implementation of change. And the cycle is to identify the audit topic, set the standard, collect, analyze, implement, and see the changes come through. And in this model, from inspections to total quality, another model where in inspections, I'll quickly just take you away from health and give an apples as an example. Inspections containing defective products, example, if you're growing apples, you're picking them, you're sorting good and bad. Quality control, exercising controls, focusing mainly on product and process. In this one, for example, you're using fertilizers on the apples, weeding, insecticides, because you're trying to, it's a line function, reactive, putting controls. Quality assurance, focusing on a company-wide quality management system oriented for prevention and long-term. Again, in the apples, here is where you're collecting data about the apple, daily inspection, your soil testing, your sampling. Basically, here is where you use audits. If you can remember what I said, criteria-based audits, systematic monitoring, and finally, the total quality, business excellence, applying collection, best management practice across the business. Again, to the apples, you have better apples, bigger apples for that matter, less bad ones, more apples, quality improvement. And for that, then there's not really not new, but used mainly newer in the market, business process reengineering, where you look at the whole strategy, 1990s, aimed to help organizations fundamentally rethink how they do their work in order to improve customer service, cut operational costs, and become world-class competitors. So that's another model, which is also used as a prototype. And these are now the examples of the actual evidence of the monitoring. I will be quick on these last few slides. It's truly just giving you a display on how you can collect, now that you know which ones you can use, how you can collect and the evidence of it. This example is on medication safety and monitoring, and it can vary from where you pick the procurement to picking one on reconciliation to another one on antibiotic stewardship, looking at elements of completeness, appropriateness, high alert medication, look-alike, etc. Another one is on blood and blood product use monitoring and evaluation. You measure this by certain indicators. You can pick transfusion reactions, patient consents for the blood, looking at the blood product identification. And remember what we said, prioritization. You don't have to pick all of them. You pick what matters, what you're struggling with, what your market is like. You might have no problems with guidelines, or you might not have guidelines. So that's where you can start, etc. Another one is on restraints use, monitoring and evaluation. Restraints is not something that we talk about much here, but you can talk through it and see in a health setup, what's restraints? In the setup that I am in, I have perhaps aggressive patients, etc. Any harm they bring to themselves and so on. Restraining in terms of medications and actual physical, what's important, what's not, what are the alternatives. Those are measures that you can look at. This one is very common for us in surgical areas, monitoring invasive procedures, post-op complications, etc., taking the consent. Another one on cardiopulmonary resuscitation, you can pick that as a composite. Within it, you look at the quality of compressions, team communications, compliance to AHA guidelines. On this one, it's an outcome measure, morbidity and mortality, which we know is a review of expected or unexpected outcomes. These ones can be in actual, significant complications that you will name, death within 48 hours, lack of concordance between preoperative and postoperative diagnosis as an example. And this last displays actual presentations of what you could see after you measured. This one I pick is on vaginal birth after cesarean sections. You actually write the indicator or the measure. And this says is that with delivery rate, which is uncomplicated. You then display it with that description, vaginal birth per 1,000 deliveries by patients with previous cesarean deliveries. You put in your exclusion. It excludes deliveries with complications, for example, preterm delivery. You have a numerator, you have a denominator, where the numerator is the number of vaginal deliveries among cases meeting the inclusion and exclusion rules, and the denominator is the discharges with that ICD code for what you're measuring. You can also have that one of general surgery pneumonia or ventilator, general surgical ventilator days beyond 48 hours. You can have infection prevention and surveillance monitoring and evaluation ones, where IPC policies and procedures, you can pick specific ones, orientation, reporting of public health matters, screening, waste management, use of personal protective equipment, decontamination, high level, low level, etc., and sterilization. So all those are actual and to the individual level. And finally, there is one on medical records, and this one you can pick on completeness, legibility, not necessarily legibility in electronics, consents, etc. Clinical, medical clinician peer review monitoring and evaluation. In this one, you can talk about peer review committees, physician profiles data, ongoing professional practice evaluations. And we know what a peer review is. It's an evaluation of an episode of care conducted to improve the quality of patient care. And that's an example. I actually pick a cardiologist. No offense to anyone who is a cardiologist. It's just an example. On this one, it's an actual report. Their score, their peer score, their target benchmark where available on behavior and professionalism, growth, clinical results, patient volumes, etc. And hopefully now as I finish, I hope that I've been able to share that different quality performance outcome measurement program models, shown you the improvement measures, and displayed some of those measures of monitoring and evaluating. Asanteni sana.
Okay. Thank you very much, Eunice, for that great presentation. It has been very comprehensive and given us a great background on measurement in quality improvement. And now it has ushered us into the second set of the presentation, and we are now going to have Florence present for us some of the great work that she's doing in Kilifi County. So if you allow me, I am just going to share her screen, and then she will pick up from there. We will have discussions, once you finish. Okay. So can you see my slides, Florence?
Yes, I can see your slides, Esther.
Okay. Please go ahead.
Okay, good afternoon. My name is Florence Luganje from Kilifi County. I am actually the county IPC coordinator, and I count it a very great privilege to be able to share the good work we are doing in Kilifi. And my presentation today, the title is Improving Hand Hygiene Compliance Using Continuous Quality Improvement Framework in Kilifi County. Next. So my presentation outline is as stated there. I'll start with the Kilifi County profile. I give you a background, the objective of the study, the implementation strategy, up to the achievement. Next slide. So that is the map of Kenya, showing us exactly where Kilifi is. Kilifi is one of the counties within the Coast Province. It borders Kwale on the north, on the south, Taita Taveta and Tana River on the west, and entirely the Indian Ocean is on the east side, and the northern side we have Tana River. And the second map shows us two facilities. It shows us the sub-counties of Kilifi County. We have 7 sub-counties, and on the map you can also see 2 hospitals, Kilifi County Hospital and Malindi Sub-County Hospital. These are very important because the operational research was actually done in those 2 facilities. Next. That is our catchment population. So Kilifi has a catchment population of approximately 1.7 million. And that is the women under childbearing and the expected deliveries. Next. Kilifi health facility distribution. Our county has more of private facilities. You can see we have 234 facilities which are private, compared to 150 facilities in the government, and 34 which are FBO. Next. So the background of this research was that effective hand hygiene is important in reduction of hospital-acquired infections. And we all know that hand hygiene is one of the WHO standard precautions of IPC. However, it has been documented that poor compliance to hand hygiene is reported in many clinical settings, including our setting in Kilifi County. So improving hand hygiene compliance is very, very important, so as we can be able to reduce the hospital-acquired infections. Continuous quality improvements, which I'll be calling CQI, is a systematic process of identifying strengths and problems and actually implementing improvements that work. And I believe that a CQI approach can be an effective strategy towards improving hand hygiene compliance. Next slide. So the objective of the study was to determine the effect of CQI on hand hygiene compliance amongst healthcare workers in Kilifi County. And finally, to improve the hand hygiene compliance in the 2 hospitals in Kilifi County. The 2 hospitals are Kilifi County Referral Hospital and Malindi Sub-County Hospital. Next. So what was done is that the Ministry of Health, with support from USAID's MTAPS, which is Medicines, Technologies and Pharmaceutical Service Program, actually conducted a baseline assessment of components of IPC program in 2 hospitals in Kilifi County to assess and identify the gaps so that they could prioritize their support. So the IPC committees were trained, were set up and trained. Then after the IPC training, they were taken through a CQI framework training, after which they sat down and came up with a work plan using the baseline data that had been collected and also using the PDSA cycle to design and implement interventions. Next. So the county and MTAPS team conducted quarterly on-site support supervision and mentorship to the IPC committee teams. And they evaluated where they are able to evaluate the implementation of the CQI work plans that had been made. And in the process, they were able to identify the challenges, then brainstorm for solutions and update the work plan. So the work plan that was created at the beginning was not the same one that took us to the end. Data was collected using the WHO 5 Moments of Hand Hygiene tool, where hand hygiene opportunities were observed, recorded, and subsequent compliance among staff documented between the period of December 2021 to May 2023. Next. So the application was done at Kilifi County Referral Hospital and Malindi Sub-County Hospitals, as shown on the map previously. Next. The stakeholders that we had were the Department of Health and the USAID MTAPS. Next. So this is what we were able to achieve At the green bar is for the Kilifi County Referral Hospital, while the red one is Malindi Sub-County Hospital. So you can all see that at baseline, that is in December 2021, our hand hygiene compliance for Kilifi County Referral Hospital was 30%, while that of Malindi was at 12%. The next findings was in May 2022. The audit for the compliance for Kilifi had moved from 30% to 45%, and that for Malindi had moved from 12 to 34%. The next year, the next audit that was done showed a drop in compliance. Kilifi went down to 28%, and Malindi went down to 20%. Then later, we did another one where now Kilifi went to 49% and Malindi went to 50%. Next. So our achievement is that hand hygiene compliance increased from 30% to 49.2% and 12% to 50%, as shown in that figure. You'll all notice that there was a decline in March 2023 in both facilities, and this is likely due to staff transition with the entry of new interns. This is the time when our interns joined the two facilities, and you can see that it is appearing in both of the facilities. So some of the strategies that, and you know about CQI, is finding out where the challenges are, come up with solutions, remedy, and then go on. So some of the strategies that we put in place when we discovered that there was a dip in the hand hygiene compliance was first to orientate and induct all interns and students on IPC. So now it is mandatory that any intern, any student, any new staff that comes into our facilities have to undergo orientation and induction so that they do not drop down our hand hygiene compliance. Then the other thing we noticed is that we did not have IC materials strategically placed. We ordered for them, and the partner, this is MTAPS, were able to bring them to us, and we strategically placed them in the hand hygiene facilities. Then in Malindi Sub-County Hospital, one of the strategies that they put in place was include the hospital administrator into the IPC committee because of the financial implication. It was easy for him to understand why we need taps, why we need IC materials. So that was one of the strategies that was put in place and replicated in Kilifi County Referral Hospital. Then Kilifi County Hospital came up with a strategy because of they saw that they were not able to do what they were supposed to do. So they came up with the idea of coming up with IPC champions for each department. For example, in each ward, in the pharmacy, in the lab. So they're the ones who are actually doing the audits. And because of these strategies, we saw that our compliance gradually increased to 50% in both of the facilities. Next. So the tools that we used were the WHO hand hygiene observation form. We also used the CQI framework, which is the PDSA cycle, the 5 moments of hygiene, and the hand hygiene infrastructure survey. Next. So this is a pictorial of the PDSA cycle where you plan, you do, you study, find out if there's anything that's can be able to be changed, you change it, and you move on, then you act. Those are the 5 moments of hand hygiene. Next. Next. This is the tool that we used, which is a WHO tool for auditing. So what are our barriers? One of the greatest barriers we had as a county is that the IPC focal persons in both hospitals had multiple roles. For example, for the one in Kilifi was in charge of the NBU, and the one in Malindi was in charge of maternity. So there was little time for IPC activities. The lean staffing levels across the facilities also was a barrier. And the high staff changeover. After you've put everything in order, the staff are changed over. Then there was loss in momentum. There's a time when both committees lost momentum. They were tired. They didn't want to move on. And then that is why we brought in the we brought in the other people to help them. Then the hand hygiene audits that were received were not printed due to financial constraints. Next. What made this a success for us is the immense administrative and management support that we got, the technical support from USAID MTAPs. In the process, the IPC government structures were strengthened, and that was a success factor. Then the availability and consistency of supply of IPC commodities, and availability of SOPs and job aids was a plus for us. The quarterly supervision and mentorship and technical support contributed so much to the success of this compliance, and the dedication and commitment of the IPC committee and the healthcare workers was also a success factor. Next. So for sustainability and reliability, I believe that appointment of a full-time IPC focal person in the hospitals will ensure sustainability. Then inclusion of IPC activities in the annual work plan and strengthening of the IPC champions. I think these ones will lead to sustainability. Induction of students and new staffs, and institutionalization of IPC audits into normal clinical practice. Next. So conclusion, indeed, CQI approach is an effective strategy towards improving hand hygiene compliance. This program should be sustained to achieve higher compliance rates. As you can see, we were able to attain 50%. Our prayer is that we will move to a higher percentage. Then we hope that this will be able to roll out to the other hospitals in the county. The county has 8 hospitals, and we are able only to do it in 2 facilities. We are hoping to roll it out to the other hospitals in the county. And also, not only for hand hygiene, but we hope to apply the CQI to improve the other processes of IPC. For example, our surgical sites infections and healthcare waste management. Next. So I want to acknowledge the Department of Health, Kilifi County Government, without whom will not have be able to do this good work. You said MTAPs, IPC committees members for KCHRH and the Malindi Hospital, and all the healthcare workers that were very supportive. The IPC champions for taking up an extra task. And this one was for the Italian agency that was able to support me to do this work. And I want to appreciate, next, I think I have another slide. Yeah, this is an example of the work plan that was made by Malindi Hospital. And you can see the aim was to improve hand hygiene compliance among healthcare workers from 22 to 50%, which they did. Next. Next, you can see that on the last column, we are able to change the indicators. This is a picture of showing one of the meetings we had with the IPC committees, the mentorship meetings. Next. At Kilifi Hospital. These are things that we were able to put up. This was a CQI training, and they were preparing their work plans. This is the Kilifi County referral team. Next. And this is one of the demonstrations of hand hygiene, hand washing during our hand washing day, or World Hand Washing Day. Next. And this is one of the IPC committee sensitization meetings that was held in the county. Next. This is another mentorship session at Malindi Sub-County Hospital. Next. And this is one of a training of the casuals, the support staff in Kilifi County. We found it as one of the gaps, and we were able to add them into our trainings, and we got support, and we were able to train them. Next. Thank you for listening to me, and thank you for this privilege to share this presentation. Thank you.
Thank you very much, Florence, for taking us from the theory into practice. We really appreciate the work that you're doing in Kilifi, and we look to hearing about more examples. So at this point, we have come to the end of our 2 presentations. But before we finish, at the beginning, I made some comments that were not clear. I said that this presentation is a partnership between different agencies. You know, the first one being the Society for Quality Healthcare in Kenya, which is an organization focused on promoting and improving the quality of healthcare services through education, advocacy, and professional development. And it focuses on all healthcare professionals. So we are also in partnership with the Kenya Medical Association, the Kenyatta National Hospital, the Rural and Urban Private Hospital Associations, the Kenya Association of Private Hospitals, and of course, the Ministry of Health. So with us today, before we go into the Q&A sessions, is one of our technical quality experts, Mr. Peter Mutanda, who has also done a lot of work with the Ministry of Health. As Eunice was talking about standards, I hope we are all aware that our Kenyan standard is defined in the Kenya Quality Model for Health, which you know, everybody in Kenya at the minimum needs to understand and at least to work towards implementing. So before we go into the Q&A session, I'm going to invite Mr. Peter Mutanda, who has done a lot of work in this area and you know, was part of the team that helped to put together the KQMH, but is also a member of the SQHK Education Committee. So Mr. Mutanda, please welcome and share with us a few thoughts before we proceed to the Q&A session.
So thank you so much, Esther, and thank you, Eunice and Florence, for the presentations. And thank you for the introduction. Yeah, we've done some work with the ministry over the many years past, in coming up with you know, the training packages, designing the core standards, so in quality measures in the country. And I know this is what applies a lot to the mass in Kenya, for the fact that I think the country has been expecting quite a vibrant uptake of you know, this quality infrastructure into the public sector, which hasn't gone to the desired levels of uptake. And I think the whole idea is that there has been a lot of momentum and interest in the last 5-6 years to ensure that people sign up to you know, the national structure, which you know, it has a guideline, there's a model, which is not really a model. No, KQMH is not particularly a model. It's just a conceptual framework that guides the country and anyone who is not maybe supported externally to come up with improvement concepts, you know, just using the IHI structure of, you know, looking at the improvement aim, looking at the structure that will make sure that you identify the changes and coming up with the necessary measurement. So on the measurement bit, which is our area of focus today, I think for me, the key takeaways is we need to focus a lot more on the practicalities. And whenever you want to do measurement, and we see this a lot in the service area, that sometimes people can also sort of bring in the measurement for research into the measurement for improvement. And there's always some distinction between the two, in the sense that when you're talking about improvement, you're collecting data or measurement for improvement, the specific area that you want to look at, it has to be something that does not take a lot of time to collect data on. You're not testing a lot of you know, statistical testing biases or any other fixed hypothesis that you will want to do in your collecting data for research. So it has to be really down to the ground of what is flexible in terms of effecting learning. What is current, you know, what kind of charts are you going to use for your improvement? We limit ourselves a lot on using the run charts, which gives us quite real-time interpretations of measurement if we are improving any area of work. And then I think the other message that I will just maybe reiterate is focusing on the process measures, because we know the structural, you know, the output and then the outcome measures are always well defined by the system. But what the team, what the improvers should be focusing on is handing this burden of measurement to the teams that are improving a particular area or a particular process. And then if you hand that part to them, they can always design their own processes and try to look at how they measure them over time. And also importantly, to link the changes that are being implemented to the improvement itself. Because sometimes you will find situations where people really, they've gone around doing quite a lot of work, identifying areas of support or improvement, while just forgetting that maybe there was something that was already in the system that would just have been tweaked slightly a bit to ensure that they have maximum or they optimize the improvement work. So I think it's very important to guide the teams on the practicality, which tools they need to look at, to use, what kind of measures, not just collect data for the sake of collection data, because systems in healthcare collect quite a lot of data, and not all of them are always used for improvement. So that burden of improving a process has to really be guided, and what kind of measures people have to put in place. So I think for me, that is very important. I mean, in the absence of very many models that are out there in many of the private facilities and maybe other agencies, KQMH has a tool, maybe not quite comprehensive. And I think the division was telling us the other time earlier in the year that they were looking at improving it, just including other components of care like cancer care. But I think comprehensively for any mid-level facility in the country, that can easily just pick the Kenya quality model, core standards and the measurement. There's an e-tool that is out there. You only need to get in touch with the division of standards to get maybe some accreditation or some access to it. Yeah. So I think that's what I would add, Esther, and then back to you. Anyone else from the society can speak to any additional perspectives. Yeah.
Okay, thank you very much, Peter, for your great insight. I think you have finally tied up everything that we have had a discussion about, and really just bringing everything together in an awareness of what is happening in our local setup. So thank you very much. At this point, I would like us to go into the Q&A session. There are a few questions online, and I would request anybody else who has a question to just put it online, then we will share it with our presenters. So I've seen a few questions about the slides and CPD points. Our admin team at KNH will share the slides and also provide guidance on the CPD points, but they are available for everybody who is present today. So we have a few questions. I have seen two questions. One of them is, how do you audit places that don't have the 5 moments, like pharmacy, where we don't have patients? Could you share if you have one? Maybe I'll ask Eunice to take this question. How would you audit places that don't have the 5 moments, like pharmacy, who don't have patients?
I see. So I suppose, I'm sorry, I suppose, so if the question is about a place which is not a direct clinical area, or the 5 moments, meaning the 5 moments
of hand hygiene.
Of hand hygiene, okay. Yeah. I see. I see. I think if you look at the hand hygiene process, it also entails elements when handling medications within the place for I don't know if I am right, but in certain areas they actually formulate the medications or the mixing and so hand hygiene is important before you move on from one tablet to another. Perhaps you're also constituting some syrups before you move from one process to another. In certain pharmacies, There is also chemotherapy handling, so hand hygiene again comes through. So there are moments in between the actual medication management safety process, but there are also moments for yourself as a handler after you've come in from perhaps dispensing with somebody or discussing a medication with a client in the area you're in pharmacy, contact with this person, and then you come back and you need to do something else. And so I think there are very many places where you can use the hand hygiene, even in the storage areas. And so I think in that way, I would use those 5 moments from where I sit in a medication safety monitoring place. There are many moments.
Okay, great. Thank you, Eunice, for that answer. Florence, I don't know if you could just also give an answer based on your experience when you're implementing the CQI with regards to places that do not have direct patients, not direct patient care areas, and how you went about it.
Thank you so much for that question. There's no place where hand hygiene is not relevant. And the 5 moments do not all have to happen at the same place. Like what my previous, the person who has just explained, even in pharmacy, there are places where you have to wash your hands. So you'll go there and only pick the moments. You don't have to pick all the 5 moments. The 2 moments, maybe when you're entering the place where you're washing your hands because you're leaving, those are already 2 moments. So, but most of practically, as we were doing this project, we were relying on the places where there was the direct clinical areas where there were patients. For example, in the laboratory, in the wards, even in outpatients, but we did not leave out places like the pharmacy, because it was important to put in that practice, to strengthen that practice of hand hygiene. So yes, you can be able to do it in a place where there are no clinical, which is not a clinical area, because at any time, there's at least 1 moment for hand hygiene. Thank you. I hope I've answered the question.
Yes, thank you very much for those insights. I think we can appreciate that really with regards to hand hygiene, every area in the clinical area, would be relevant for healthcare workers to wash their hands, and we can find our way of assessing it. Okay, so we have a second question. Rhoda, can you hear me? I don't know if Rhoda or Dr. Oktoi can hear me, but the second question is around how long are results of surgeries tracked in Kenya? 5 years, 15 years, 35 years, or do you assume that everything is okay once the consultation ends?
Hello, Esther. Yes, I can hear you.
Yeah.
Thank you, Musandu, for that question. And I think this comes from the presentation that was made earlier on by Eunice Tolle. So maybe Eunice, I'd like to throw this back to you from the data that you presented about tracking and measuring. How long, maybe in your hospital, you could guide us on how long you track patient results. And then Dr. Oktoi could tell us from a regulatory point of view or a licensure point of view, how long should be the correct number of years. But of course, we don't assume everything is okay once the consultation ends. When does the consultation start? When does it end? Maybe that's something also Dr. Oktoi will clarify to us. Back to Eunice.
Okay, I will attempt to answer that, and thanks, Rhoda. I think for me, truly, as we've heard, your selection and appropriateness of which indicator to pick, even within the operative and invasive procedure monitoring, is dependent on a lot of things. I've said you prioritize. What is it that you're struggling with? From where I sit, indicators and measures, in terms of timeliness, in terms of how long, is based on your targets and benchmarks. For example, if truly you had put this as an indicator to perhaps reduce post-procedure hair complication in an X procedure specifically, maybe myomectomy specifically, and you then begin to see an improvement after 3 months, in our setup, you will never drop that indicator even if you shoot up. Actually, one of the indicators of measure is a sudden rise in your improvements or a sudden drop. So even a rise is an indicator of, oh, so what happened? As much as we implemented it, does it reflect a sustainable data? So in our setup, we tend to drop indicators if, based on all standing, it picks up, it sustains. We tend to keep the indicator for at least 3 years. By the 5th year, we call it retiring it, not eliminating it. So you may not see it on the regular dashboard. It does not mean somebody somewhere is still not collecting it. So it's the way we do it, 3 to 5. However, there are those that you do very well, and I'll allow the regulators to speak. There are those that you do very well, but if it's a regulatory requirement or an accreditation requirement, you don't drop it, because whatever happens, you must report them. So those are the 2 ways we look at it, 3 to 5 for the regular ones, which are not a regulation or a standard that's of measure for the certifications you might have.
Thank you very much, Ms. Tolle, for your response. At least, I mean, it's to do with the indicators. I think I understood the question the other way, like how long do we follow up these patients? After how long can we say that an outcome is attributable to a certain incident that happened during, for example, procedure? I think that would likely be individualized, as Ms. Tolle has mentioned, but we are aware that for the surgical site infection, in the definition, I think it has a limit of, we will define a surgical site infection as having, let's say, an infection after the procedure and up to, I don't know whether it is 3 months, but it is something that is very specific. However, for the other outcomes, it likely depends on what variable or what procedure we are talking about. And if it is in contention, in Kenya, usually in contention, it is a peer, a panel will be able to discuss that. For example, if that leads to if that leads to somebody being sued or it going to the board for the purpose of some action by the medical disciplinary committee. So it likely depends on what. However, at a public health point of view, we choose that which can help us do reflection. Madam Tolle has mentioned about the various measurements and metrics. So for whatever issue that we are handling, there is what has been called as a standard, that this is the standard for this specific issue that is in this indicator. But for each of them, for an institution, we need just to reflect on it. And so the common reflection is the performance measures that we track either monthly or they're part of what we've put on our dashboard as indicators. But beyond that, could there be any outcomes? I think the question of whoever raised it is, could there be any outcomes that may not be captured by this indicator on your dashboard because it happens, maybe, for example, after 6 months, that's when we get. So that should still concern us, quality improvers, or in wanting to make us have better outcomes. We need to be curious. So when patients start presenting with outcomes that are related to an incident that happened longer than our tracking period, as an institution, we still go back and look at those outliers and see what does that mean to the improvement that is needed. could we be needing to track this patient a little longer? A good example is COVID, where we continue learning that people got immediate effect. And after that, we've been tracking to learn what are the other impact of COVID. It's just to do with the disease, but some could be to do with the kind of care we gave. So that is just a good example. So I think in quality improvement, we need to be curious, and our desire is better outcomes, improved processes. So whatever that means for any indicator, we'll retain it in what we are using, but at the same time, we may extend the scope beyond how it is defined within our reporting or what we routinely do for the purpose of learning, because we still can push that to other non-QI learning, for example, into research now to find out, oh, this was a case study, or this happened beyond our expected. So what does this mean? We need to revise. Those are my thoughts concerning what has been raised and how Rhoda just brought it up. Thank you.
Thank you very much, Dr. Okutoyi, Eunice, and Rhoda, for those remarks. I think it has been a great afternoon of understanding measurement in quality. And I think going by the events in Kenya today, any healthcare provider should now be very aware and take a keen interest in measuring quality, because this discussion of quality, just like every other thing on the scene of our country today, is slowly but surely going to move away from boardrooms and meeting rooms in our hospital to the public domain. And so we are now going to be held accountable on a bigger scale for the outcomes that we have. And therefore we cannot run away or, not take this issue of measuring our quality seriously. If we cannot measure the quality, then we can never know whether we are improving or not. And so we cannot know, what works and what does not work. So in summary, I think, all of us need to identify what would work in our areas in terms of quality measurements or quality improvement measurements. Of course, on the basis of what is not working, of what needs to be improved, and then put in place measures that, we can start monitoring. And I look forward to a day when we can all start sharing our results on different issues, really at the national scales, because it is only in knowing how we are performing, sometimes in comparison to others, that we can learn in terms of what works, what does not work. So, the Kilifi example is an excellent case. If they roll out the project on the whole county scale, then they will definitely find some hospitals or some facilities that are doing extremely well compared to others. And they can use that as learning opportunities so that overall the quality of care is improved. So at this point, I would really like to thank all of us for joining and participating in the session. And I would now declare it closed. Thank you very much and have a lovely evening.